Hello, welcome to the EKG Guy. Today, what I wanted to do is go through this question that we had posted, looking at essentially what is this pattern here? So these patterns in V1 and then in V6, is this a right or left bundle branch block pattern? Okay, and then essentially go through it, give you the answer, walk through, and then make sure you understand why you see what you see on the EKG, at least that pattern. That's because that's like the main purpose of why we do these videos, why we have our courses, are to ensure that it all makes sense and you're not doing all memorization for learning EKGs, which you shouldn't. So my name is Dr. Anthony Kashu, and many of you and thousands of you are taking our courses and getting credit from it. So thank you so much for your support. What I want you to do here is, if you haven't, try to determine if this pattern here is right or left bundle branch block. You can pause the video and then restart it when you're ready. So let's look at this, okay? So essentially, let's first go through name this cardiac cycle, okay? So starting from the beginning, and we'll start here in V1. So V1, okay, which is one of our right precordial leads. So our right precordial lead, will essentially put it right here, okay? So this is where V1 will sit for our purposes. Again, not anatomically correct, but it'll work here. And then we also have V6 here. So V6 is this one, and we're gonna put it here. Let's put it over this edge, on the edge, okay? And then we have a few other leads there. Let's put one here, and we'll put high lateral lead AVL up here, okay? So let's take a look at this, naming this first cycle in V1. So V1, this first positive deflection is what we call a P wave, representing atrial depolarization, okay? Then we get to this QRS complex that I want to name, and this first component here is an R wave, okay? Then this here is an S wave, and so here is a R wave, and so that's where this RSR complex comes from, okay? That's where that name comes from. And then here at the end, you have what's called a T wave, representing ventricular repolarization. Now, doing a similar thing in V6, our lateral lead, left lateral lead, here's the left side of the heart, here's the right side, so this is a left lateral lead, V6, you have your P wave, okay? And then you also have your QRS complex, okay? So this is your Q, okay? You have a big R wave here, and then you have this S wave here. And so that's where the name QRS comes from. Small q, big R, small s. And then here you have your T wave representing ventricular repolarization. So hopefully that makes sense. That's just naming those. So again, a right precordial lead, a left precordial lead. Those are the leads that sit right on your chest from the right side to the left side of the heart. And now when we look here, what we have displayed is pretty much the cardiac cycle in the heart. So just to orient yourself, here is the right atrium, okay? So this is our right atrium, okay? You have your left atrium, which is here. So this was your left atrium. Then you have your right ventricle. So we'll put this right here. So your RV, your right ventricle. And then here you have your LV, your left ventricle, okay? So hopefully that orients you. You also have up here your superior vena cava, okay? Down here would be your inferior vena cava, essentially bringing deoxygenated blood to the right side of the heart. And then this is how it's all laid out, okay? Now, the thing that I want to focus, and essentially what EKGs are doing, is looking at the electrical activity of the heart. And so here is where the conduction system normally starts. Up here in your right atrium, you have your SA node. So here's your sinus node. So SA or sinus node, you may hear it. And then you have conduction through these internodal fibers that come to what's known as an AV node, okay, the atrioventricular node. You also have a component here that goes and depolarizes these interatrial septum and into the left atrium, called a Bachmann bundle. Okay, and then from this AV node, you have a His bundle, the bundle of His, and then you have a right bundle branch in which conduction goes down, and then the left bundle branch. The left bundle branch subdivides into an anterior posterior fascicle. The anterior fascicle of the left bundle branch innervates the anterior and superior portions of that left ventricle. Now, the other component, the left posterior fascicle of the left bundle branch, which is not shown here, innervates the inferior as well as the posterior wall of that left ventricle. And from those bundle branches and those fascicles, you have conduction that goes through the ventricular Purkinje system and to the cardiomyocytes. And essentially, that's how conduction spreads throughout the heart. So that's kind of the conduction system. Now, our main question here was this right or left bundle branch block pattern, okay? So based on this, and I'm just gonna let you know, this is what we call a right bundle branch block pattern, okay? And we're gonna go through this to figure out and know why you should know these features, but making sure the features that we discuss here are going to make sense, okay? So let's look here. So imagine that you have conduction that's coming through, okay? But then there's a defect on the right side, so on your right bundle branch, meaning that conduction cannot pass through that right bundle branch and thus cannot innervate or depolarize that right ventricle. So what happens is you have conduction coming through and it bypasses through the AV node, through the His bundle, and is not able to get through that right bundle branch, but still conducts down the left bundle branch. Okay, and because it conducts down the left bundle branch, there's one initial vector we should know about. Okay, and these initial vectors are essentially forces, electrical forces that are displayed. The greater the vector, the greater the amplitude of most things that we see on the EKGs. There could be some exceptions, but for our purposes, that's what it means. So the first vector is a left to right vector, okay? And this first vector we'll label number 1, okay? So first vector, let's just put it here. We'll just label it like this. Okay, so that's vector number 1 going left to right, and that's coming from the left bundle branch. And essentially, what that's doing is depolarizing the interventricular septum. Okay, so that's where you get that left to right force coming about. And as a result, notice where that vector is coming to, from the left to the right side towards V1 and away from V6, okay? Because it's coming towards V1, that's where you see that initial small R wave, okay? So this one right here, that small initial deflection is coming from that left to right force. The vector is coming towards V1, going away from V6. So that's that first vector, okay? It accounts for the small R wave we see in V1, okay, that RSR prime, and the Q wave that can be seen in V6. So that's vector 1. The second thing is conduction continues down the left side of the heart, okay? And it's able to depolarize the left ventricle. As a result, the left ventricle is depolarized and you have a second vector, okay? So vector number 2 is heading in that direction from the right to the left, okay? Notice it's going from essentially the V1 lead and going towards V6. So you have a positive depolarization wave heading towards V6, and as a result, this is where you get this big R wave occurring, okay? That R wave occurring in V6 is a result of that. And the S wave occurring here is because this depolarization wave is heading away from V1, okay? So that's where that comes about. And finally, the left ventricle has now depolarized, and now it has to come back and depolarize the right ventricle. Because remember, conduction could not pass through that right bundle branch. And so as conduction comes from the left side of the heart, the left ventricle to the right, you have this slow cell-to-cell depolarization wave coming here and depolarizing the right side of the heart, the right ventricle. And so the third and final vector is essentially a slow one. I'll draw it like this, and it's going from left to the right, okay? Remember, this over here is the left side of the heart, and this over here is the right side of the heart, okay? So that's that final vector. And so what does that final vector account for? Well, again, look where it's coming. From left to right, it's coming towards that right precordial lead, V1, and as a result, we get this big R wave upstroke, okay? And that's that slow cell-to-cell depolarization, that main vector that you're seeing account for that. And it also accounts for this S wave that you see in the lateral precordial lead. So here's V6, that vector is moving away from it, and so that's where that S wave comes about. That negative, that terminal negative deflection in V6, that S wave is a result of that. Okay, so hopefully that makes sense. So let's just kind of recap some of the findings that you can have. That way you can have them written down and in your toolbox and ready to go. So again, this is a characteristic right bundle branch block. Not all of them present the same way, and there's a lot of caveats, but you want to know what to expect first, and then we can start getting into all the nuances. So first off, a duration of 120 milliseconds or greater. So what does that represent? Well, that's the QRS duration, okay? So this is the QRS duration, meaning the width of it. So when you look at this, okay, the width of the QRS. So imagine that you have a QRS complex. Here's our RSR prime. The width is from the beginning to the end. So that's what I mean. And essentially, when we look at any bundle branch block, notice that we did not mention anything about these P waves. The P waves represent atrial depolarization, essentially things that are happening up here in the atria, okay? Atrial depolarization. Everything we discussed was down here in the ventricles, the left and right ventricle. And so when you think of intraventricular conduction defects or delays, we're essentially looking at the QRS being affected, okay? And also the T wave and the ST segment can be as well. But the QRS is essentially where we're looking for the pattern to diagnose these right or left bundle branch blocks, okay? So the QRS duration wide, okay? Normally 70 to 110 milliseconds in adults, even shorter in kids as they're even younger. But adults 70 to 120 or 110 milliseconds is normal. Okay, once you hit that 120 millisecond mark, then that is considered prolonged, okay, in our adult patients. Now, one thing to keep in mind that I'll just mention here is that when we look at and we see a pattern that we'll discuss here, the QRS duration is what separates incomplete from complete bundle branch block. And so what we're looking at in this case is complete. What would separate the two, okay, you may hear this, of incomplete right bundle branch block is essentially also the QRS duration. Okay, and the duration in that case is less than 120 milliseconds, but it still has all these other factors that we'll look at. Okay, so hopefully if you see complete versus incomplete, the only thing that's separating is the width of that QRS complex. Okay. So, and it should make sense why the width is prolonged, okay? We said that conduction could not come down this right side so that later terminal force is slowly depolarizing from the left to the right side, and that accounts for the width, the prolongation of the QRS complex. Now, the next thing is what is happening in V1 and V2? Well, what you want to look for is a prominent R prime wave in V1 or V2. So we're looking at here the right precordial lead. Here's V1. Okay, you can also say that is also occurring in V2. So maybe V2 is about here. Okay, so often similar. So this is the R, here's your S, and this is your R prime. And so the R prime, that terminal deflection is the main one. Remember, that was vector 3. Okay, so vector 3 as it moved from right or from left to right accounted for that. And that's the main one here. And you want an R prime that is large, okay? It tends to be a little wider because of this slow cell-to-cell depolarization, okay? So the other thing that we saw there was this RS. So think of, you can have an RS R prime, you can have an R small s R prime, okay? But the main thing in all of these that you want to keep in mind is that the R prime, okay, is greater than that initial R. So that second wave here, that second R wave there, is greater in amplitude than that initial one, okay, representing right ventricular depolarization. So hopefully that makes sense. Now, the next thing I want to look at is what's going on in V5, V6. So V5, you can imagine over here. So V5, okay, V6. So you can say these are also the lateral leads, and we can also add lead 1 here, so 1 in AVL, essentially all in the same areas. V6 and lead 1 are essentially in the same location, just you have precordial leads and the limb leads, different horizontal and frontal planes. So V5 and V6 sitting there, and what we're going to see in V5 and V6, what do you think? Well, it's essentially the main thing that we're looking at is that terminal thing, that terminal wide, you can say S wave, and this tends to be also slurred, okay, meaning so wide slurred S wave that you see there in that terminal deflection, okay, in those lateral leads. So keep that in mind, the S wave there as well. what's going on with the ST T wave changes, okay? So we don't see them in this image, but what's commonly seen are what we call discordant. Okay, so discordant STT changes. So what does that mean? So imagine you have this QRS complex, okay? Here's your R, here's your S, your R prime, okay? And then imagine this is, say, lead V1, okay? So we're looking at V1, here's your RS, R prime, and then imagine what would happen. You start to get your dipping. So some depression, okay? ST depression, which would be this component at your J point, and here's some T wave inversion. So this is what we call discordant changes, where your main QRS factor is positive and your terminal STT segment is negative, okay? And these are expected changes in right bundle branch block, okay? And that's why that T wave is negative here, but you also may see not only that T wave negative, but ST depression here. In contrast, in V6, in the lateral leads, you may see ST elevation and upright T waves, okay, as your main terminal deflection may be negative, okay? So discordant ST T wave changes are expected in right bundle branch block and even other bundle branch blocks. So any intraventricular conduction delay may have the discordant changes and does not suggest ischemia. In fact, if they're concordant, meaning going in the same direction, that may in fact be a sign of ischemia. Now, the other thing we want to think of is the QRS axis. And the QRS axis is essentially going to be normal, okay? Normally, the QRS axis represented by the first 60 to 80 milliseconds of the QRS complex is not really affected here. The cases that you may see it affected may be in a left anterior or posterior fascicular block if you have that as well, okay? So that's one thing to keep in mind. All right, so hopefully that makes sense. There's a lot going on here, but again, just to recap, what's going on? Our criteria for complete right bundle branch block, you're looking for a QRS duration that's wide here, okay, generally 120 milliseconds, which remember that would be 3 of those small boxes or square, okay, in width. That's because of that left to right force depolarizing the right ventricle. You want to look for a dominant R prime wave in V1 and V2, okay? And you want that R prime to be greater than that initial R, okay? And as you start to learn how to differentiate wide complex tachycardias, this is a component that helps differentiate VT and supraventricular wide complex tachyarrhythmias, okay? Namely that if you see a typical right bundle branch block pattern in a wide complex tachycardia, it's most likely coming from above the ventricles, okay? So on the other hand, if you see an atypical right bundle branch block pattern, it may suggest VT is present. So knowing this is well worth it beyond just knowing to characterize and identify these patterns, but also differentiating VT or not. Because essentially that is, one of the most complicated things we have as physicians and clinicians across the board to differentiate. Is it VT or not? It really affects how we immediately manage patients, the ensuing workup that we have, as well as the long-term workout, the prognosis for the patient. So knowing these patterns goes well beyond just identifying if this is present or not. Because if an incomplete right bundle branch block pattern is present in maybe a young person, that may be actually a normal pattern and not really have clinical significance. Okay, so back here, and then we saw discordant changes. Remember, discordant changes are expected with these intraventricular conduction defects, and particularly right bundle branch block. You can see ST depression, T wave inversion in the right precordial leads, and you may see ST elevation and upright T waves in the lateral precordial leads or lateral leads, okay? And again, the axis tends to be normal. You may see a rightward shift. The axis may be affected with an left anterior or left posterior fascicular block as well. So hopefully this makes sense. Again, if we get back to the answer in this pattern that you're seeing there is right bundle branch block, okay? I hope you found this helpful. I know so many of you have ordered our Foundation Secrets book, so thank you. We're going to get to about thousands more out this week. We have our Diagnostic Secrets Guide, okay? We have so many books. We have our Ultimate EKG coding breakdown, more geared towards cardiology fellows or cardiac rhythm analysis technicians. We have a lot of other books here. We have one of our second edition, our first edition, our courses. So again, if you're looking for pacemakers, whatever it is, we hope to have it. But again, when you join our community, our goal is not to just provide you these resources, right? But also to help you grow, help you to learn, and help you to actually learn these concepts so that you can improve the care you deliver to your patients. Thank you so much for your time. I hope you have a wonderful day.